Thank you, Dr. Afterhadi, for your remarkable leadership of this effort. It was only a little less than 60 years ago that these three people proved that if you compress the chest rhythmically, you can prolong the time before you have to exert defibrillation. Let's look back from that time until now to see what were the major public policy changes that influenced this field and survival. In 1967, the National Research Council, a group not unlike this one, endorsed the training of the public in CPR. And the American Heart Association, American Red Cross grabbed the idea and really led the world in training bystanders in cardiopulmonary resuscitation. In the late 1960s, Cobb and his colleagues in Seattle advocated for use of firefighters as first responders, an enormous advance in the technology and the delivery of defibrillation and CPR to the public that was universally endorsed by public policy really across the country. Then in the late 1990s, the American Heart Association really entirely led the charge toward public access defibrillation. The American Heart had a number of public meetings to advocate for this with the press and government, the FDA, and then saw to it that although imperfect, they changed the law in every state in the United States to include defibrillation under the Good Samaritan laws. And then finally, as NHLBI was set to fund the study, the PAD trial published in 2004, but when I called them in 2001 and I said, I want to activate the IDE for the experimental use of a defibrillator in human beings, they said you didn't need to get an IDE because, in fact, the public policy was that defibrillation, as labeled on the product, was okay for use by any informed bystander. I would say that more recently, hands-only CPR, a major advance in resuscitative skills, and I would say dispatcher-assisted CPR is work in progress, as revealed in our own agenda today with regard to a major public policy advance that advanced resuscitation. What is the characteristics, what were the characteristics of all 5 of these advances in public policy? They're singular, notable advances. They have a solid scientific basis. They captured the public's imagination and the public's interest in using these developments. And finally, they achieved multiple endorsements in order to become informed public policy. So where do we go now, and what are exciting advances that could become part of public policy that could advance resuscitation science in a major way? Renee Merchant yesterday gave you a full introduction to the Pulse Point initiative. I'm going to comment a little bit further on what it means and what it does. The Pulse Point people take a cell phone and will take a picture of an AED wherever it is, and from the GPS system on the cell phone, they know where that defibrillator is. When a 911 call comes in from a cell phone, they will know immediately where the arrest is. They have volunteers who have their cell phone on that they find in the neighborhood of that arrest. They guide them to the nearest AED, and they guide them then to the arrest situation to do defibrillation. From the Pulse Point Foundation's own website, the implementation of this program has been very small in the United States. There are significant pilot programs going on in Los Angeles and Seattle, but if this approach got significant endorsement and public backing and so forth, this could, in my view, make an amazing difference. The second issue that could potentially rise to this level of importance is to equip police and use police as AED first responders. Wouldn't it be nice to be talking about the good things police are doing these days in the United States for the public? The science here is based on the work of Rudy Koster in the northern part of Holland, where in a population of 2.4 million people, he implemented the program of equipping every police vehicle and including police vehicles as first responders. What you see here is a graph from 2006 to 2012 showing you that the frequency of bystander chest compression or bystander CPR didn't change very much during that time. The public location arrest and the witnessed arrest didn't change very much. Already, as shown on the left-hand line, upwards, the 2005 guidelines were fully implemented. But what changed during this period of time was the use of AEDs, as shown in the dark line, going up across the slide. This is more details of that rise in use of AEDs by the public and police and the decline in AED use by the EMS system. So in the light bars, you can see that bystander use of AEDs in this community went from about 5% to 11% over this period of time, whereas the use and shockable arrest of the police AED went from 15% to almost 50% of all shockable arrests. Here's a summary of his data, or the data of this group. On the left, you see the increase in overall survival from cardiac arrest in 2006 versus 2012, rising from 16.2% to 19.7%. All of that increase was due to the center panel, the increase in survival of shockable arrests that increased from 29% to 41%, correlated with the increase in AEDs used before EMS arrives by bystanders and by police from 24% to almost 60% of all shockable arrests. On a continuing basis, the increased AED use accounted entirely for the increase in survival from cardiac arrest. So, in summary, these are two advances that we could make in public policy that would meet the criteria of being singular advances based on solid science that potential would in fact capture the public's interest. And all it is needed are multiple and important endorsements and implementation across this country. Thank you very much for your attention.